Hi, it's Dr. Centeno, and thanks so much for joining me today. We've got an interesting topic, and that topic, I've also got a little cold here, so just bear with me there. That topic is the suboccipital muscles and how they interact individually with craniocervical instability or craniocervical syndrome. And I've talked about these before in the context of a group of muscles and sort of a little bit about what they do, but never talked about them individually. Also, this would be my last live. I'll be out for 6 weeks, but I'll actually be doing pre-recorded lives once a week starting next week. So I've got 5 of those set up, which will take me through to the time when I return. And the goal there, obviously we won't have a live Q&A, but there'll be new content and a new interesting video about CCI symptoms and tracing those symptoms back. So those are going to go, that's going to start going out next week. There'll be a Facebook Live and we will get started with today's lecture here. So let me go ahead and share my screen and we will go from there. Okay, so we're going to do a deep dive into the 4 suboccipital muscles and craniocervical instability, or CCI. Again, I've talked about these as a collection before, but never really individually in what they do and why. So one of the critical roles of the upper cervical muscles, in addition to balancing the bowling ball on top of the stick, meaning your head on top of the neck, is proprioception. So proprioception is position sense, and they're really a major position sensor for the head on the neck. And that information, as I've talked about before, gets coordinated with information from the eyes and the inner ear to provide normal balance. And just some interesting data on how big these muscles are involved in proprioception. So most human muscles have about 12 muscle spindles, and those are sort of position sensors per gram. But these are the suboccipital muscles. The inferior oblique has 242 per gram. The superior oblique is 190 per gram. Rectus capitis posterior major, 98. Rectus capitis posterior minor, 98. So pretty interesting stuff here. We've got about 20 times, 10 to 20 times, depending on the suboccipital muscle, the number of position sensors in these small muscles that help to balance the head on the neck. And that's because they're so involved in normal balance that they provide an immense amount of information about what's going on with head position. So we'll go through each one of these. We can see here the 4 suboccipital muscles. And this one here, rectus capitis posterior minor, rectus capitis posterior major, will be the first 2 we talk about. Now, one of the things you can notice about rectus capitis posterior minor is it goes from the head to the atlas, and the major goes from the head to C2, or the axis. So head C1 and head C2. What you can't see here is they kind of cant backwards, and I'll show that to you in a little bit. So that's the posterior major there, and the posterior major, and then that's the posterior minor. Posterior major goes down to C2, posterior minor goes to C1. Now, one of the things that's really interesting about these muscles is the myodural bridge. The myodural bridge is what connects the muscle into the dura. And in particular, the rectus capitis posterior minor is connected into the dura, or the covering of the brain. So this is one mechanism for dural headaches when the suboccipital muscles get very, very tight. Literally, this pulls on the dura. Now, what's the function of having this muscle jacked into the dura? It's believed that it helps to get rid of dural infolding as you bring your head back. And then another thing that's incredibly important to understand here is that forward head position causes 3 times the activation of these muscles, the posterior minor and major. So if you've got a neutral head position, they're not all that active. But if you have a forward head position, which many of us do because we do this all day looking at our phones, or looking at a keyboard or looking at a computer screen. So one of the ways, if you've got suboccipital tightness back here, to try to get rid of that is to get rid of that forward head kyphotic posture. Because not only does it cause stress on these muscles, but it also causes stress on those upper cervical ligaments as well. So again, in this position, head back, they're not working very hard. But if you do this or this, they're working really hard. And that also makes a difference because the occipital nerves, the greater and third occipital nerves, snake through these muscles. So if these muscles are overly tight because of that kind of behavior, then they are going to irritate the third occipital nerve and greater occipital nerve, which is going to cause headaches and or burning back here in the head, and or a feeling of your head is tingly, all of those things. Now, the obliquus capitis inferior muscle is interesting because you see here that it goes between specifically C1 and C2. And it's the only one of these suboccipital muscles that doesn't attach directly to the head. Now, that's pretty interesting, right? If you've got a C1, C2 rotation, this is an interesting muscle for you. So again, this obliquus capitis inferior muscle rotates C1 and C2. So if you're going into an upper cervical chiropractor and they're constantly dealing with C1, C2 rotation, then it would be worth getting a good hands-on exam of this obliquus capitis inferior muscle to see if it also has tendinopathy, for example. And that would be the actual muscle on one side not working well because the muscle tendons are injured. Now, the good news is when we inject these upper cervical facets, we will always inject, for instance, PRP or whatever it is we're injecting as we leave the joints. That gets the posterior capsule of, let's say, C1, C2 here, but it also gets these muscles. And between injecting 0-1, 1-2, and 2-3, which would be very common injections for CCI patients or CCS patients, these upper cervical muscles are getting bathed. Now, in some patients, you might also need, under ultrasound guidance, to inject the specific muscle tendons here at C1 and C2. So this is something to think about, again, if you've got that going on. Now, you can also palpate it on yourself. C2 is going to be the big knob in the back. So as you start from the very top of the head, you'll go through C1, which you can't really feel the back of. But as you go down, you will start to feel a bony prominence in the midline, and that's the C2 spinous process. So if you go just to the left or right of that C2 spinous process, you can see if that's a tender area for you. And that's something good to let your doctor know about. If I'm your doctor, then let me know about that. You can also go up from there and to the left and palpate the back of C1 and see if that muscle tendon or that upper part of the obliquus capitis inferior muscle and the tendon there is very tender. And then finally, we have the obliquus capitis superior muscle. And this is also an interesting one, right? We see there that we have this dedicated C1, C2 muscle in the inferior. And in the superior, we kind of have a dedicated 0-1 muscle. And that would be in addition to this muscle here, which would be that rectus capitis posterior minor. So if we look at this from the side, we can see that superior oblique here is going across C0, C1. And the same thing would happen in the rectus capitis posterior minor back here. So these are muscles that specifically control 0-1. So if you have a chronic 0-1 problem, you might want to look at these two muscles. Again, the rectus capitis posterior minor, in addition to the obliquus capitis superior, or what's also sometimes called the superior oblique muscle. And again, these are things that can be looked at on a hands-on exam. And it's always great to see a patient who's palpating around for these muscles. So base of the skull down to the back of the transverse process of C1. And, when a patient comes and says, "Doc, right there is where I have issues." And I've seen that in a lot of patients. We've treated that in a lot of patients where they come in and say, "Yeah, what's going on right here?" And that is the lateral transverse process of C1, right where this superior oblique muscle takes its origin. And so we inject that specific spot. Now, this is also a spot that's frequently injected when we're injecting the AO ligament or the lateral AO ligament, excuse me, as well. So this is something that we frequently inject at that transverse process. And then, as always, be careful when anyone's injecting these muscles. You can't do these blind. I've outlined in yellow here where the vertebral artery is. And remember, this is the artery that supplies blood to the back of your brain. So if you inject inadvertently into this artery because you're not using guidance and you don't understand what's going on, you just stick a needle in here, then you're going to stroke the patient out. So again, be very careful. And this is at least an ultrasound guided injection. And if it's under fluoroscopy, then it needs to have digital subtraction angiography with contrast to make sure that you're not injecting into this vertebral artery and stroking the patient out inadvertently. Obviously, it's an awful thing to do to cause a stroke in a patient when you were just trying to see if you could help another problem. So in summary, the suboccipital muscles are pretty unique. They're major position sensors of the brain. They have an immense density of muscle spindles or position sensors within them at 10 to 20 times what's in a normal muscle. They can spasm in cases of poor posture, which can then irritate the occipital nerves and cause headaches and other things. And they can control the positions of the C0, C1 and C1, C2 facet joints and those levels. So if you're someone with a chronic 0-1 problem, the rectus capitis posterior minor or the superior oblique might be two muscles to look at. If you're someone with a chronic C1, C2 rotational issue, then that inferior oblique may be one to look at. Okay, so that's what I have today here. And let me get out of that and we'll see what questions we have. Rishi, thank you, Rishi. Yes. My mom had been pretty ill for quite some time. And those kind of deaths where they happen and you're like, she was so young and vibrant, or she was old and vibrant, but she had been in bed for 2 years, not comfortable. And so it was actually a blessing. So thank you for your condolences. Rishi, can you inject all the rectus capitis muscles and suboccipital muscles during PICL if it's needed? Yes, they all can be targeted. Darian, what do you think of HA injections mixed with PRP and stem cells? Does Regenix do HA? Yeah, Darian, I think we've got some reasonable information out there. A couple randomized controlled trials that seem to show that if you add HA to PRP, you may get a longer effect. I don't think that that is completely answered yet, but I think we have some good information on it. So I think there's very little reason not to do it if the patient requests it. It does add cost. And the data on PRP being effective in mild and moderate NEOA, for example, is so strong. Also now being a DMOD, a disease-modifying or disease-modifying osteoarthritis drug, meaning reducing cartilage breakdown, that I don't know that it's needed, but if the patient would like to do it to see if it provides some additional benefit, it's not a problem at all. Rishi, if a patient's atlas is out misaligned, then undergoes the PICL procedure, how would this affect the healing outcome? I presume ligaments will heal misaligned. Would it be better to see an AO a day before? If this one has never seen AO or chiropractor before, Rishi, if you're excuse me, if you're going to do that, then just make sure that you have that relationship established before the procedure. We have most of our patients that do very well with NUCA and AO chiropractic, but we have some patients that don't. So that's why we would like to see this relationship established before the patient comes out, and so that you know that you're a responder. Now, I can't say that the patients that don't do well with this do more poorly. So I don't think it works like that, meaning that if we inject a ligament that isn't really damaged, we're not going to see much change in that ligament. If we inject a ligament with free collagen and exposed collagen, it's going to PRP, bone marrow, or other orthobiologics are going to impact that ligament differently. But again, it inherently makes some sense. But we just want to make sure that you have that established beforehand. So I would say about 7 to 8 out of 10 of our patients have an upper cervical chiropractor on board, but we want to make sure that that person is on board and the person is responding before they're seen for their PICL, so that we're not just introducing that as something new after the PICL. Rishi, I understand no procedure without risk. However, what is the clinic's protocol if a patient wakes up mid-procedure during PICL? Is procedure abandoned? Or would the patient, given signed consent beforehand for the procedures, keep going if woken mid-procedure? Yeah, so I think I've talked a little bit about some of this before. And what I mean by that is that at the end of the day, realize that if you're on CBD, on THC, low-dose naltrexone, narcotics, all of that increases the anesthesia requirement and makes it harder to keep someone asleep. So it's not all that uncommon that the patient might momentarily break through anesthesia, but just realize 98% of the time the patient doesn't remember it because of the drugs that are being used. So we deal with that all the time, meaning it's not something that's a surprise to us. It's something that we work around and have never had an issue or problem with. Now, breakthrough anesthesia, is the patient might come a little bit more conscious and then we give them more medications and put them down. We're not talking about someone bolting upright in the middle of a procedure or anything like that, which generally is not something I've seen happen. But, realize that we work with it. We then give the patient more medication, put them down, and then generally proceed. Now, every once in a while, and this is the reason why I always bring up these issues of taking these medications and THC-related drugs, is that we can't get as much done in that person because they're a pain in the neck to put to sleep. And so for example, if you do a lot of THC, you're probably going to be what I call a tightrope patient. And that is that we're either going to be need to give you 3 or 4 times the amount of medications as anyone else to keep you asleep, and or you're going to be wide awake. And so in those patients, we may get less done because we need to get less done to keep the patient safe. So if you want to get the maximum done, get off all that stuff for quite some time before we see you. Rishi, if you had to say from experience what the hardest type of CCI instability to treat, what would that be? Well, there's one that's any harder that I've seen than any other. I can say that the easiest one to treat is a type 3A, and that's with C2 goes forward on C3 in flexion. And that's easy because that person many times will get better with just simple posterior neck prolotherapy. So we may not even see many of those patients, because if you tighten these ligaments back here in those patients, they'll do pretty well. AT, what type 1C instability is C1 pressing into the dura during extension, or is the mild bridge failing to pull the dura during extension, or both? Yeah, so 1C would be sliding of the skull on the atlas. So if we're getting backwards sliding, you could certainly see that these muscles would be loose and the myodural bridge wouldn't function to pull the dura out of the way in extension. Rishi, could a misalignment of the atlas neck cause trigeminal neuralgia? It's possible, yes. I mean, we see trigeminal neuralgia in CCI patients. It's not the most common symptom we see or problem we see, but it is maybe 10% of CCI patients, so it's common enough. I don't know that it's due to a specific type, other than I would say that could be more related to those types of instabilities of the skull on the atlas based on how the 5th cranial nerve exits the skull. Andy, for moderately severe type 3A, how many prolotherapy treatments would it take on a typical EDS patient? How about plate lysate mixed with dextrose? Yeah, I don't know what moderately severe is. You'll have to define that. But for most patients with type 3 instability, that's the kind that would respond to just posterior prolotherapy. We'd be looking at 2 to 3 treatments, somewhere in there. Perhaps a few more in an EDS patient, and we'd want to make sure that that person was getting iterative improvement with each one of those. Russian, what's the difference between plate lysate and PRP? Do you ever inject lysate in the epidural of the C-spine? Yeah, so platelet-rich plasma has whole platelets, and those whole platelets degranulate over the first week to release growth factors and exosomes. Platelet lysate is where we break open the platelets to get those growth factors and exosomes out, and we use those directly in plasma. We do inject platelet lysate into the epidural space of not only the cervical spine, the thoracic spine, and the lumbar spine. Rishi, how many PICLs do you perform a week roughly? Are there often multiple in a day you do? Yeah, on average right now, when I'm in clinic, I'm performing about 6 a week. And the most I think we've ever done in one day is 4, I think. And on average, usually 2 or 3, somewhere in there. So that gives you some idea. Now, obviously, I'm out of the clinic 3 months a year now, 2 6-week periods. So obviously none during that time period. Andy, you mentioned how it's somewhat common to see injectate leak out of an arthritic facet. Have you seen this go away anytime in a patient with subsequent treatments? Oh yeah, I've never seen the contrast in there at some later date. So yeah, it's absorbed pretty quickly by the body. Based on other studies we've done in a vascular space like that, it's not going to last more than an hour or 2. Levon, how long should you wait to resume running post-PICL? Levon, that's one that you'd have to ask your physician about, and I can't disclose any confidential medical information here online. So that one's got to be approved by the doctor. Ian, cervical ligaments heal via PICL treatment. Would a CXA theoretical increase, reducing brainstem compression caused by an acute CXA? Yeah, Ian, I've talked about this one a lot, and it's, I think, an important one to understand. At the end of the day, clavoaxial angle, or CXA, which is the degree to which the skull is rotated forward, it's not, the problem usually isn't a low CXA. The problem is a low CXA in neck flexion is usually what's happening. So that then causes the issue. So the goal there would be to have the CXA maintained from neutral to flexion by tightening various ligaments. It wouldn't be to somehow increase the CXA in neutral. So just realize that it's usually not a problem of a low CXA in neutral, although there's some out there like that. It's mostly that the CXA collapses inappropriately when the person looks down. John, do professional sports teams in Colorado, their coaches or team physician consult with their clinic during the season? For example, athlete needs PRP after a recent injury. Yeah, John, we can't disclose any of that stuff, but just come to our office and you'll see professional athlete pictures all over the walls. Many of those are Colorado, sometimes not. So, well, I can't disclose that. Those athletes, signed pictures for us and gave us permission to put those on the walls. So if you want to see who those are, just come into the office. Regenetics been advanced by Sherry Scott. Is it possible to have CCI and recover on your own? Sure, there's probably a lot of acute upper cervical ligament injuries that lead to some form of CCI that recover enough on their own that we never see them. Obviously, we're blind to those patients because they never seek specialty care. John, the future, what do you see being developed that will be stronger than BMC? Yeah, I think we will eventually see in the United States autologous cultured mesenchymal stem cells be available. We have one of those products that we licensed that's now in a phase 2 FDA trial. And so we'll probably see those here in the next 3 to 5 years. That would be a bit stronger than BMC, not as much with ligaments, to be honest with you, but for other things. And we'll eventually probably see genetically modified stem cells that will also get on the market, sort of super cells, but those are further down the line. AT, do most patients that are one and done, you have observed have more of an immediate improvement response within the weeks, full 4 to 6 months of general healing versus? No, I don't think they heal any faster. It's been advanced by Harry Winston. It would be great to have you on the same side of the world for a while. Yeah, I will be in Europe for 6 weeks. So I will be on the other side of the pond, as it were. AT, can CCI cause pulling on muscles attached to ribs? Would it be possible at a later date, if you make a video on all the different muscles below the neck, CCI can affect? I think I have one on that. If you go to the Facebook channel, my Facebook channel, and you just type in scalenes, I'm pretty sure that will come up. So scalene muscles are ones that are attached directly into the ribs and also attached to the upper cervical spine. So just go to the Facebook Live YouTube channel, or just the YouTube channel itself, my YouTube channel, search under scalenes, and that should come up. Hey doc, remember when I emailed you that video of the lady with severe TMJ hypermobility? Have you ever treated TMJ hypermobility that severe in your clinic successfully? What did you use? Yes, we have. There's a story on the Regenix.com, 2X's website. If you go there and you just search, just type in TMJ, I think it's called Valerie's story. Valerie was right in there. She had extremely severe TMJ and happened to have CCI, so she got treated for both. So that might be an apropos one to look up. Ian, do you think forward head posture can cause an acute CXA and would improve posture, increase the CXA? Not like that. I think what can mess with the CSA is loss of cervical lordosis. I have seen that. Forward head posture would tend to increase the CXA and not decrease it. Eliza Mara Garado. For an L4-5 herniated disc, they did 100 million stem cells, PRP, and exosomes to me. What do you think that approach was? I have low back pain and neuropathy in both legs after a microdiscectomy 3 years ago. After my procedure, I saw like 30 shots all around my back. That doesn't sound like a credible provider to me. So I'd need to know a lot more. Did they do that? Did they do that with X-ray guidance, with contrast confirmation? Which provider did that at which clinic? I could tell you more if I knew those things. 100 million stem cells part sounds like they used dead amniotic or umbilical cord tissue without any living stem cells. Exosomes are a scam. So we have no FDA-approved exosome products right now. The PRP sounds credible, but the question is exactly how was it injected? Meaning if all they did was inject into your back muscles and call it good, or maybe back ligaments and muscles, then they didn't put it in the right spot. So I need to know a lot more than what you have. So feel free to put that in comments and I'll take another look at it. Connor, can the C1 drop on the anterior side? If you mean, can the anterior part of C1 go inferior? Yes, we've seen that, and that would be usually due to those anterior ligaments that go between C1, the front side of C1 and the skull. And those can be targeted in above atlas PICL approach. AT, I use a lot of screen time to distract myself from symptoms, but it causes eye strain. Any significant consequence of this in relation to recovery, already having visual issues in general? Yeah, biggest time of screen time is probably posture. So if you're doing this, that's a problem. Obviously, if you're really working on have everything set up correctly with regard to your monitor height, you're using a lumbar support, you're making sure that you're constantly monitoring whether your head is back, then that would be better. Mohan, any patient from India where you've done a PICL? Yes, I believe we've treated patients from India. Mohan, EDS population is mainly Caucasian women with a small amount of Caucasian men. Have you ever seen an Indian male with EDS? I don't recall if I've seen an Indian male with EDS. Darian, why is the knee joint more likely to become arthritic than the ankle joint, even though the ankle joint is subjected to more weight? I think knee injuries from a ligament standpoint tend to be a bit more common, but I don't know that there's a huge prevalence difference. I think what we tend to see is that knees can become arthritic in metabolic syndrome. So the biochemical changes when people put on weight that happen seem to impact knees more than ankles. But God, there's a lot of ankle arthritis out there. So that's a common one for us to see. Connor, on my MRI, my atlas looks higher on the posterior side and lower on the anterior side. Yeah, Connor, we would need to look at something like a DMX to see what happens there, but certainly good information to start with. Jim, PRP usually helped my suboccipital tendons completely retighten those attachment points with a single PRP treatment. Great to hear, Jim. It's been advanced by Roberta Mann. Hi, Centeno. I have an appointment to get a DMX. What do I need to do to be evaluated by you? Yeah, Roberta, you would need to reach out to our team and just reach out to our team at Centeno-Schultz Clinic. Tell them you have craniocervical instability. They then will have you fill out a CCI questionnaire. From there, you can get a telemedicine booked. So that would be the next step. Book, doc. Is there a relationship between the jaws, palate, CCI symptoms? My CCI symptoms seem to get worse when I push up forwards on my tongue on the palate. Yeah, there's a big relationship between TMJ and this whole anterior stabilization mechanism and CCI. It's one of the reasons why getting the stylohyoid ligament cut in an Eagle syndrome surgery can be so devastating to certain CCI patients, because we're destabilizing this anterior mechanism. And many of our patients, they start to stabilize their head through the neck using that mechanism, using those muscles that are attached to the jaw. Jim, there's a recent video made by Brian Hutchinson, chiropractor, who claims he dry needled these occipital tendons to fix tendonitis without he was anywhere close. You can dry needle them. You have to be careful, because we've seen at least one subdural hematoma caused by dry needling of this area. And obviously you would want to use ultrasound if you were going to dry needle this area. Carrie, is the healing curve for other areas of the body post-injection the same as that for upper cervical PICL, SI joints, ribs, lumbar ligaments? No, everything's got a little different healing curve. So for example, SI joints tend to tighten up in the 4 to 6 week time frame, for example, whereas for some of these upper cervical ligaments through a PICL, we're looking at 3 or 4 months. So it gives you some idea of some differences there. Barbara, thanks for all you do. Hope you have a great trip. Oh, thanks, Barbara. He says, recommended to rest more head and neck against something and wear your collar post-PICL. You need to be careful with the collar, right? Because the collar is a two-edged sword. It will cause muscle atrophy, which will wreak havoc in other ways. So the answer to the question is you want to be as active as you're able after a PICL. It's been advanced by DB. Could vagus nerve issues be caused by other things than CCI and other neck issues? Absolutely. Ian, if PICL stem cells heal ligaments, why is it often said that people need to keep going back for further stem cell type treatments many years later? Haven't really seen that, Ian. So I'm not quite sure what it is you're hearing or whatever. Obviously, I treated, I don't even know how many patients at this point, maybe 10,000 or so. Patients with ligament issues, with, in general, with PRP, stem cells, prolotherapy. We generally don't see those patients back. As far as PICL is concerned, once we're done with a patient, we generally don't see that person back until they have another injury. So, for example, I just saw one of those. This was a patient we treated early on, maybe 2017 timeframe. She did great until she got into another car crash 5 years later. So generally not my experience. Carrie, are your recommendations for activity, PT, after injections to other areas of the body than cervical, upper cervical, different than those for PICL? Yes, very different, depending on the body part. Crockett, yesterday I had a PICL procedure done, but only Z0, C0 through 3 levels, meaning facet joints, were treated. Levels from C through T1 were treated, even though my DMX report cast chiropractic showed damage. Facet gap at C4-5 level. I just choose to opt out of treating below C3 level and just go ahead and treat all levels of the cervical spine. Everything we do is, and I think we talked about this, Crockett, when you were on the table, but everything we do is we treat symptomatic facets. We don't treat asymptomatic facets because it's a risk-benefit equation, meaning for each facet level I inject, it adds risk. So we don't just treat facets to treat facets. As far as C4-5 facet gapping, I don't believe that's an actual thing. That's a common degenerative change as the spine starts to get sloppy as we get older. And so, as I think I told you when you were in the clinic, probably half of your friends who have no neck pain or neck problems would have C4-5 facet gapping. You don't have any symptoms there. Half of your friends who don't have neck pain have this problem. There's no reason to treat it. John, when you first started specializing in upper neck, well before PICL was created, did you believe overhang was caused by C1C2 capsules? Then you're thinking change with experience. No, yeah, John, not really. Again, we don't really have data that shows that overhang is related at all to C1C2 facet capsules. And that wouldn't make a lot of sense given the position of the capsules and the position of things like alar ligaments. Now, facet capsular laxity posteriorly, which is really what you're talking about here, right? The capsule goes 360 around the joint. So it goes in the back, on the medial side, on the lateral side, and on the front. So I think you're just talking about posterior capsules aren't going to provide a lot of stability. We inject them on the way out of the joint. But do I believe that tightening down the C1C2 facet capsules is going to get rid of overhang in the vast majority of patients? I don't have that experience, nor would that make sense based on what they do. Kara, I saw you a few weeks ago for my consultation. You actually did a video about my case. I'm the one who had QRI decompression. You mentioned I'm not a great candidate for regenerative medicine because of my decompression surgery. Do you think I should go straight to neurosurgery for fusion or try PRP first, knowing that it may not be as effective? Kara, I can't specifically talk about your medical information here, but what I can say in generalizations, and this is probably a good topic to bring up for everybody, when we see Chiari decompression surgeries, it's pretty tough on the upper cervical spine. And I think I've talked about this before, and that is that the muscles in the suboccipital area, the ones we're talking about today, many of those are destroyed by the surgery. In addition to that, we've got big parts and pieces that are taken out of as well. So for instance, the posterior skull, and that can wreak havoc with the upper cervical issue. And that's one of the reasons why when we see Chiari malformations, I think we have to be very, very careful to try less invasive things first, rather than just going to the most invasive thing, which is to do a Chiari decompression. As far as whether or not you need specific things, that would be better to reach out to me privately, because I don't think it's a good idea to discuss your personal medical data online here. Levon, do you inject posterior longitudinal ligament just from one side of the neck? Posterior longitudinal ligament is going to be on the back side of the disc and the front part of the spinal canal. So there's really not an easy way to get to posterior longitudinal ligament if you're talking about something like C2, 3, 4, etc. Now we can get there during a PICL if we need to, and up there, that posterior longitudinal ligament, which is really the same structure, is called the tectorial membrane. So that's something that can be treated. As far as treating that below that, it can be treated, but it's a big deal. You've got to go through and through the disc. You wouldn't want to come from the side. You'd have to come from kind of an anterior lateral. So again, it's not one that usually gets treated, but it's also thankfully not one that usually needs to get treated if we're talking about down here. Kimmy, is there vertebral compression or IJV compression, or if there is there a chance PICL will make that worse, even temporarily, or is it something PICL should help with? So I think you're talking about IJV compression. So here's the concern, Kimmy, and I think I've talked about this before here, but in case you didn't catch those, it's important to note that IJV compression is normal. I must say that again. It's important to note that IJV compression is normal, meaning that when we look at studies that are just performing CT angiography or CT venography for other reasons, having nothing to do with IJV compression, even at severe levels bilaterally, is present in 1 in 5 patients who have no symptoms at all. And if severe one-sided, 1 in 4 patients, and if we're talking about moderate, 1 in 3 patients with no symptoms. I think what you're talking about instead would be that that certain patients get more IJV compression with CCI. So if that's what's happening, is we're seeing more IJV compression with instability, then the goal is to stabilize. So we shouldn't see more in that case, we should see less. But again, I think it's important to realize that IJV compression, as it exists, is a normal condition that doesn't cause symptoms. Where a patient can run into problems is when they've got IJV compression that happens intermittently with a change in head position, and that's more due to instability. Kara, well, I haven't received notes yet, I believe, from my DMX that I had a type 2A, and I think you mentioned slight 3A, 3B. Gotcha. Rishi, my earlier question about seeing AO was in regards to if someone was misaligned, didn't know they were. I've never seen AO in my life, but suspect I might be misaligned. Yeah, so Rishi, again, I think it would be good to see an AO before you come out and try to see if that helps your symptoms, because then you'd be able to work with that provider after to try to keep things aligned. The guy 420, do you think MDMA good for PTSD? Maybe. I'm not an expert in drug-assisted psychotherapy, so not my thing. I will tell you that if, again, you're using drugs like MDMA, it's going to mess with anesthesia. And I think we've already had that conversation. Big ones we see are CBD, THC, low-dose naltrexone, dramatically increase anesthesia requirements and anesthesia risk. Kimmy, does PICL help with loss of lordosis, or something we need to see a chiropractor at PT for? With PICL, we always inject the posterior ligaments there to support the lordosis, but if you have a lost lordosis that's causing symptoms, then it's also good to be working with someone on curve restoration. The big thing for CCI patients would be, can they tolerate it? And that's always a question. Or do we need to treat the CCI first before they can tolerate the curve restoration? Max 84, if the muscles of the neck are so strongly spasmed that flexion, extension, rotation are limited, is there not a negative impact on the reading of angles to evaluate CCI or AAI false negatives? You could certainly get a false negative that way. And so there's two things that can really cause false negatives in movement-based imaging. One is the muscle spasm you're talking about. The other is the patient not being pushed hard enough to get enough range of motion for us to see a problem. Now, if it's muscle spasm and it's quite severe, we can usually give the person some Valium or other muscle relaxer and then re-image that person. But those are the two things we see with movement-based imaging that can cause problems. NARS. In my report, it mentioned I have mild grade 1 anterolisthesis of 213 inflection. What's the best treatment for this? So that would be a CCI type 3A. The good news is that X-ray or ultrasound guided just posterior prolotherapy of the supraspinous interspinous ligaments usually help with that problem. Now, you also many times have to inject the C23 joint directly, and that would be an X-ray guided fluoroscopic procedure with contrast and digital subtraction angiography to be able to do that. But some of those patients will just get better with tightening down the posterior ligaments at C2 and C3. Others will require that plus injecting the joint directly under X-ray guidance. James, is it okay for PICL patients to come to Colorado for the procedure by themselves? No, we generally don't like that. If it's something that can't be helped, then we can get you a nurse for the first night because we want a patient advocate there. If you were to have any issues, problems, it's good to have a patient advocate there who can assist you and help you. Also to help you get in and out of bed after anesthesia, things like that. So it's generally not ideal to come alone. Much better idea to come with someone else. Nisa, if the PICL procedure does not work for the patient after a few tries, what are some of the things you may suggest for the patient to do in order to support their healing from CCI? Yeah, if it's not working after a few tries, we're probably not going to continue down that road. So in general, obviously every case is different, but in general, we're then going ahead and recommending that that person move on to surgery. Rishi, if I do upright flexion extension MRI, we only look at the images and not the report. Reason for asking this is if I'm picking between Medsarena and upright MRI of Colorado, Medsarena is much more expensive. They specialize in imaging for CCI. However, if you're only going to look at the images, then it's worth just getting an MRI clinic in Colorado. Yeah, I would just do it in Colorado then. I don't read the reports. You and I are going to spend more time looking at that MRI than the reading radiologist will ever do. And so if there's a big price difference, then I would go with the Colorado one. Ian, what is typically causing the majority of symptoms is CCI if there's no obvious brainstem compression? The CXA is 120 in neutral, but increases in both flexion and extension. I get head symptoms every time I walk or move. I'm wondering what this could be if not compression or pulling on the brainstem. Yeah, a dozen different things. So again, Ian, could be due to the C0, C1 facet joint, the C1-2 facet joint, the C2-3 facet joint, the greater occipital nerve, the third occipital nerve, the lesser occipital nerve, the cervical sympathetic chain. I mean, those are just a small list of things that can cause problems and symptoms, the vagus nerve, et cetera, et cetera. Now, one of the things that we've been doing in patients with CXAs that low is we've been going ahead and imaging them using diffusion tensor imaging in that area just to confirm that there is no problem, meaning just because on a routine MRI the cord looks normal there doesn't mean the cord's normal, because things like diffusion tensor imaging or DTI can show in much more detail whether or not there's actual fiber tract disruption in that area. But assuming there isn't fiber tract disruption in that area due to the low CXA, then a dozen different things can cause symptoms having nothing to do with spinal cord at all. Connor, an EDS patient, if their ligaments are elongated, therefore making the skull unstable, those ligaments classes as damaged or deformed, and does PRP shorten them? My personal case, I have EDS instability everywhere. My ligaments feel very elongated and deformed. Wondering if you could explain further on this. Yeah, so the goal in EDS patients is to thicken their ligaments. Now, they're not going to ever have completely normal ligaments, but the goal is to get their ligaments stronger so that they can then get their muscles stronger. And between those two things, get out of pain and move out of the instability category. So we're talking about ligaments that don't respond normally to stretch. They stretch more than normal ligaments. And, realize that EDS patients normally start to get symptoms in their 20s and 30s. And there's reason for that, right? We all start to get wear and tear on our ligaments. And for EDS patients, that happens quicker. But there was a time in there where the ligaments were working just fine or good enough. Kimmy, if there's data yet on recovery from CCI versus PICL based on the length of time since injury, my injury is 10.5 years old, keep mostly functional with the AL for 5.5 years, concerned about the length of time since injury. Yeah, Kimmy, as I've always said, if you've had this for a long time, then there's just a higher chance of permanent neurologic problems setting in. Now, if you've been mostly functional with AO for 5.5 years, that's a good thing. But there's no doubt that if you've had this problem for a long time, there's always that risk that certain aspects of the neurologic issues can become baked in. Obviously, less so if you're staying in alignment and you're functional with AO. Connor, in terms of severe bobblehead sliding rather than heavy head, you say this is hard to fix with PRP. If you're talking about a CCI type 1C, generally in an EDS patient, generally we would use bone marrow for that. Irvin, Centeno was diagnosed with hip labral tear. Doctor told me you're a candidate for PRP. Can PRP help the hip labral tear? And when should I expect to feel pain relief after a PRP procedure? So Irvin, you'd want to make sure the doctor, depending on your age, you got a little picture there, but let's say you're 40 years old. If you're 40 years old, then you'd want to make sure the doctor is using high dose PRP. You'd want to make sure the doctor is using ultrasound to be able to inject the labral tear, and pain relief after a procedure like that would be 4 to 8 weeks, somewhere in that time frame, maybe as far out as 3 months. And also, depending on your age, again, labral tears are normal. I'm going to say that again. Labral tears are normal, meaning that high numbers of athletes without pain or problems have labral tears. High numbers of middle-aged people without pain or problems have labral tears. Labral tears are a normal variant of aging, just like meniscus tears. They're about as important in general as wrinkles. So there's probably other reasons that your hip hurts outside of the labral tear. Doesn't mean labral tear can't be targeted during a PRP injection. It just means that it's usually not what's causing the pain. John, for CCI, you've had patients who were told by their neurosurgeon to consider the PICL procedure. Sure, yeah. We've had several of the CCI surgeons. We just had one this week who patient went and saw the CCI surgeon, said, yeah, continue doing that stuff. That stuff doesn't work. We will be happy to intervene. Kimmy, sometimes my C1C2 pain and symptoms can be relieved with adjustments to my sacrum. Would it be advisable to also get SI joint injections? What kind of imaging would you want to see before deciding if that'd be a good idea or not? Yeah, generally imaging of the SI joints doesn't give us a lot of information like it does in the upper cervical spine. So I would say there that it's a good idea in those patients. I think you've got the right idea to treat both ends of the problem, meaning treat the upper cervical spine if there's CCI, and treat the SI joints at the same time, assuming the patient can tolerate it. But imaging the SI joints, regrettably, just doesn't give us a ton of info. Connor, if a person's head feels stuck in a chin tuck in a neutral position, is this related to the CXA? Usually that would be related to instability at C0, C1. Does conventional CBP address forward head posture? I know it addresses the curve, but a lot of before and after image appears the curve is fixed and the head's forward on the body. They should be also addressing posture, yes. With X-ray, Ramirez doctor in Mexico, intradiscal and L4-5. Yeah, I don't know that doctor. I know that most of the clinics I've reviewed in Mexico are a scam, meaning that they aren't actually injecting the disc when they claim to be injecting the disc. But I don't know that doctor in particular. I can tell you that, again, exosomes are a scam. PRP is real. And I would, certainly if you want to, feel free to send me the images. So I would get the images and you should see, the needle going into the disc, and you should see contrast in the disc, etc. So, but I don't know that particular doctor, but most of the clinics I've reviewed in Mexico are a scam. Adina, can loss of cervical lordosis decrease the space between C1 and the styloid and lead to compression of the jugular vein after structures in the carotid sheath? I think you bring up an important point, and that is changes in the curve can impact things like that interval that you're discussing between the styloid and C1. But again, just realize, so yes, absolutely, getting a normal cervical lordosis, assuming you can tolerate that, is a great first step. And just be cautious here, because the whole Eagle syndrome thing is concerning in that long styloids are normal. Again, I'm going to say that again. Long styloids are normal. I'm going to say it a third time. A long styloid on an X-ray or CT scan is normal, meaning that a large segment of the asymptomatic population have long styloids. It's just calcification of that styloid ligament that's coming down there. So be a little careful with all of that stuff. NARS, I was told there was evidence to suspect ligamentous laxity or injury involving the anterior lennox-occipital membrane, right posterior lennox-occipital membrane, and the apical ligament. What's the best treatment for this? Probably PICL, assuming you have symptoms that are CCI related and are disabled by those symptoms, but there's a long way to go from there. With X-ray intradiscal, yeah, I think I've already said best thing to do would be to send me the images. I'm happy to take a look at those. As far as stem cells from a bank, again, concerning, and the PRP is legit. As to what really got injected in Mexico, I'd have to look at the images to tell you, because most of the Mexican clinics I've reviewed are a scam. Rishi, this is the first time doing regenerative medicine. Apart from blind prolo, would it be possible to get treated aggressively above and below the atlas? Seems my first time. Yeah, that's likely possible. And guys, it's I'm going on 1 hour and 3 minutes. I'll probably do about 5 more minutes just because I've got to start packing here pretty soon. Kimmy, I got my notes from Sherry saying you had diagnosed me with type 2B, but it was not mentioned how many treatments I may need. Is this something we discussed prior to treatment, or is it something you figure out? Average number of treatments is 2 to 4 treatments. About a 1 in 5 chance of being a one and done. Less likely if the problems have been going on for more than a year or 2. Clinic, Regener Art in a surgery room. Yeah, again, I'm happy to look at the images. Like I said, I've reviewed more Mexican clinics at this point than I can count. Most of them I've seen are a total scam as to what's being done versus what they're telling patients. So the only way I could tell would be to, without knowing the clinic, would be to review the images. Darian, can you show the trial with the Regenix product stronger than BMC? Is it on PubMed? Not quite sure what that one means. Which Regenix product stronger than BMC? Kimmy, atrophied muscles in the neck, something we should work on prior to PICL. Should wait until ligaments are stronger. Yeah, Kimmy, if you can work on neck strengthening, then that's always a good idea. Many of our CCI patients can't do that, but if you can, then that's a good idea. Connor, have you had a case where someone's entire spine is unstable and you've gotten them back to life? Sure, my niece. She's in the UK. I'm gonna see her tomorrow. So yes. Eliza, the exomes, I'm not sure. I didn't understand. Maybe part of the PRP, I didn't understand. Yeah, exomes are a scam. And so that would be the scammy part of what I'm hearing. But again, I would need to see what it is they injected by the fluoro images showing contrast in various structures. And I could tell you if it was a legit placement or not. Great. Ian, do you think there would be any benefit having head in a halo vest brace for several months? No, I think that'd be a really bad idea. Sharon, hi for Centeno. After AO adjustment, my head gets floppy and it just feels too loose. Does it mean it's unstable? And I need regen. Sounds like that could be. AT, is there in the past, you've said, right, red light laser therapy cannot penetrate the bone, ineffective for alar transverse, can effective in aiding healing of interspinal, supraspinous ligaments. Yeah, I think that's an easier target to hit with that kind of thing. Hypermobility has become more recognized by surgeons during doing Chiari surgeries. I heard that at Iowa Children's Hospital, they do the bite and test on every patient to see if fusion is needed as well. That's a good one. Meaning that's a good trend for sure. Robert, is there an AO doctor near your office? Yeah, we've got several really excellent ones. Dr. Schuster being one of those. Very experienced AO guys who trains other AO guys. Robert, PSEL package includes injections. Don't quote me on this, Robert, because I'm not doing billing and all that other stuff, but I believe that it includes 0 through 3 facets, the posterior supraspinous, interspinous ligaments, and any upper cervical work that we do. Crockett, with my PSL having been done yesterday, how long do I need to wait to start curve correction, schedule another PSL procedure? So Crockett, we always give it 3 or 4 months before we schedule another PICL procedure to see how you did with the first one. As far as start curve correction, that's something that you'll need to reach out to me directly on. We'd want to see a substantial amount of improvement in your ability to tolerate a rolled up towel under the curve of your neck when you're lying face up on a hard surface, meaning kind of artificially putting a little curve back in there and seeing if that helps or increases symptoms. Rishi, if someone's misaligned atlas neck, could PSL make this work? I think I've already answered that one. Guys, I'm going to try to go through and just get a few questions here, answer that I haven't seen before. What's my opinion on 3D images of CT angiogram with the venous component? Never heard you ask for it. Yeah, because the biggest issue there is internal jugular vein compression is normal. Again, I'm going to say that 3 times like I've been saying these things. Internal jugular vein compression is normal. Internal jugular vein compression is a normal finding, meaning that these are common compressions are commonly found in asymptomatic patients, even severe compression. So while we've seen a few people where we've ordered this because it looked so substantial, we wanted to get more information on it, it's not something that we spent a lot of time thinking about, because if the person has CCI, then the goal is still to treat the CCI. And if I order a CT scan, I'm exposing that patient to 100 or more chest x-rays of radiation. So that's the reason why we don't do that often. Kimmy, if symptoms are not relieved in a collar or some relieved with AO, does that indicate poor or better odds of PSL being successful? it's something that we like to see for sure, meaning it's one of those things that helps us not see if the PICL is going to be successful, but make sure it helps us know that instability is probably causing the symptoms. And we go through a lot of discussions with the patient about that. How sure are we that we can help because we're sure that instability is causing your symptoms? James, yes, we do have a nurse that you can hire while you're here. Regarding IJV compression of CTV or MRV, it shows blood trickling thin. Is this still normal? Yep, still stone cold normal. Meaning 1 in 4 patients undergoing a CTV for something totally unrelated has severe bilateral IJV compression, and they've got no symptoms. So IJV compression is a normal finding. Crockett Savage, if I have loss of disc height in L4 through S1 maybe, I have no pain, wise treat these levels? No, it's never wise to treat asymptomatic levels at all. Sharon, what are your thoughts on wearing a hard collar for CCI? Again, I think as I've said many times before, and I think this is the last question because my wife's going to kill me if I don't start packing here pretty soon. Collars are always a two-edged sword. If someone wants to wear a collar very intermittently, like when they're traveling or if they're riding over a rough road in a car, that's one thing. I think that's reasonable. But collars will also reduce the muscular stability, and half of stability is muscular and half of it's ligamentous. So that's the big concern on collars. Okay, guys, so as I said, this will be my last live Q&A for a while, although I will have a new video about symptoms in CCI and tracing back the cause of each one of those symptoms called the CCI Symptom Series that will be released over the next 5 weeks. I think those are being released on Fridays at 1 p.m. Mountain, so 3 p.m. Eastern, and 12 noon Pacific. Obviously, you guys are free to discuss amongst yourselves in comments there. Those will be going out on Facebook Live, so they'll show up on the 2 Facebook channels, Regenix and Centeno-Schultz, as well as on the YouTube channel. And at that time, so those are already done, set to go out. So you guys have content that you can review each week. And then I'll still be seeing telemeds while I'm out. So I'll be continuing to see patients and more answering questions on an individual basis. And I will be back in 6 weeks doing more Q&A. And look forward to seeing you at that time. You all have a great weekend, and I'll see you in just a little bit. Thank you much.